This session with Mr. Luc Puy. We are going to start the abstract session. We want to get the program started right on time today. We are blessed with the opportunity to listen to 5 wonderful abstract speakers this morning. We have a gal that is going to be running back and forth from the pediatric session as well. So we'll have someone joining us as well from that session. So we're going to go ahead and get started. We're going to get right on time today. And we're going to start today with Dr. Condello speaking to us today on magnetic levitation pump versus constrained vortex pump. So if you could please welcome all of our speakers today, and we will have time at the end of this session for questions and answers. So please write down your questions and we'll be sure to get to you. Thank you for joining us early this morning. We're happy to have you. Please, sir.
Hi, good morning, everyone. It's a great pleasure for me to introduce this presentation about magnetic levitation pump versus constrained vortex pump, a pilot study on the hemolysis effect. I am Ignazio Condello. I come from Italy. I am a cardiovascular perfusionist. This is my disclosure for this presentation. And it's really important, the integrity of retroside membrane to assess the microcirculation and to improve Fareus liquid effects and plasma skimming. During the use of extracorporeal technology that involved the use of roller pump, we observe an increase of plasma-free hemoglobin during the extracorporeal technology. The deleterious effects of plasma-free hemoglobin increase the liver damage and the acute kidney injuries after use of extracorporeal technology, and increase the incidence of inflammation, thrombosis, and immune dysregulation. In the literature, the elevated plasma-free hemoglobin is associated with multi-organ injury. In this context, we start with a study between 2 technologies, the magnetic levitation pump versus the constrained vortex pump, centrifugal pump. And we collected data on 196 patients underwent cardiac surgery procedure for coronary bypass artery grafting. We excluded the patients that have individual risk for anemia and hemolysis, and we included the patients underwent coronary artery bypass graft with the use of minimal invasive extracorporeal circulation. We excluded 156 patients, and we included only 40 patients consented to participate in this study. This is the study population. We divided the 2 groups. In the first, that use ECMO life in MEAC with 20 patients, and the second group use AP40 that use vortex pump. The primary endpoint is the evaluation of plasma-free hemoglobin 10 minutes after cardiopulmonary bypass, the lactate dehydrogenase after 24 hours, the indirect bilirubin at 48 hours, the creatinine, and total red blood cell unit administered intra and postoperatively. We use during the conduction of cardiopulmonary bypass a monitoring system for cardiac index, oxygen delivery, central venous pressure, pressure drop, and other parameters. And this is the drawing of our circuits. Is a MEAC type 4 from MEACTIS classification. This is the use of minimal invasive extracorporeal circulation during KBG procedure with S5 pump and console. This is the 2 pumps in the first group, the magnetic ECMO Life by Eurosat, and the second group use Affinity AP40 by Medtronic. The results are really interesting. The patients in between the 2 groups are really homogeneous in variables for Euroscore, hemoglobin, serum creatinine, plasma-free hemoglobin. And during the conduction, we have a good conduction on goal direct perfusion, hemoglobin value, good oxygen delivery, and mean arterial pressure. Nevertheless, the results are really different because the magnetic levitation group reported a low plasma-free hemoglobin at 10 minutes after coronary arteries bypass grafting, low levels of LDH at the end of the CPB after 24 hours, a reduction of creatinine peak, and allow administration of the red blood cell and improve the reduction of indirect bilirubin. In conclusion, our pilot study suggests that the use of magnetic levitation pump in this context for high value of hemoglobin prevents the risk of hemolysis and increase the biocompatibility of the pump and the circuit. And I concluded this presentation, and a larger study are needed to confirm our results. Thank you so much for your attention.
Thank you. Great job. Thank you. Thank you, Dr. Condello. That was awesome. Our next abstract presentation will be by Dr. Maurya on efficacy assessment of retrograde autologous filtration on adult patients undergoing cardiopulmonary bypass and cardiac surgery. Thank you. Oh, sorry. Should just be. It's on the drive. Yeah. Look, he closed it out. Sorry, one moment. We just need to open up his presentation.
This one?
There we go.
Like this. Good morning, Excellencies, and good morning to everyone and my dear friends. I'm from India, all the way to present and discuss about one of the research topic, which is rough. I will tell you the whole story, how it has been started, why we developed this technique. Actually, we conducted one survey in the 2021, which came to conclusion that 300 institutions of India has been participated, and we have got to know that 80% of the center are doing adult cases. The pediatric and the neonates cases are less than 10%, but and 13% will be the mixed cases, means they do adult as well as pediatric both. So keeping that on the mind, we had also came to know that everybody was using hemofilter commonly. They were doing cuff, that is 70%, and they were doing muff on 16%, and the pre-bypass ultrafiltration, that is 10%, and the less than 10% is Z-buff they used to do. But what we came to conclude on that thing, that while going on pump, we are facing lots of problems related to hemodilution. Yesterday, Mr. David from University of Michigan has pointed out about the hemodilution thing. So that is main, what are the challenges we see, that we had one of the group of patients, those are saying that we cannot take allogenic blood. At the same time, we have to get the surgery done. So both the things they want, but they don't want transfusion, and we do avoid the transfusion. But it comes to when the point comes to the hemodilution, it becomes really tough for us. So what hemodilution could make has been pointed out by David, Mr. David also, but I am presenting them again, that maintenance of hemoglobin as soon as we go on the pump. And the unstable part, that is most of the unstable part, is the mean pressure, which fall down as soon as we go on the pump. Supporting that, we have review of literatures, means that after immediate initiation of bypass, we had seen the sudden falling of the mean pressures and the change in circulatory physiology, like capillary leak, and those where lots of problems which occurs, and it leads to sudden drop as hemoglobin level, and it also leads to drop as a viscosity of the blood. And So the hemodilution was a serious problem. So it also leads to poor oxygenation to the organ, which leads to ischemia on the pump. So we came up with the solution that among every of us will know that shortening down the tubing and to reduce down the dynamic volume. But that is not the solution at some point, because if we will cut down the tubing and we will reduce it down, we will come to the 1040 ml of priming solution, which will again, when we go to the dynamic volume, it will increase to 1200 ml. But at the same time, the emptying out venous line technique, that is a VAP. Yesterday, Mr. David had talked a lot about it, that VAP and RAP. But the RAP is also having the same problem, that it is a teamwork. So in that, what we face is, again, the falling of blood pressure is the common thing. So we have to concern with the anesthesia. So to avoiding that, we had started with doing the rough technique. The main reason to start is to control the blood pressure falling from sudden falling. So rough is in itself labeled as a retrograde autologous filtration. So what happens in the rough? It allows us to empty out the arterial line, and the speed of falling hemodynamic, that is the mean pressure, it will not fall, or it can be done in a short time. So as the name suggests, retrograde is the taking out the fluid from the arterial line. It doesn't mean that we have to empty out the arterial line, but the crystalloid solution, crystalloid isotonic solution, which used to partially mix with the blood. So we have to take out that isotonic solution out and the blood thing remains in the line. So filter is we do as we hemofilter. That is the thing. And the autologous is the thing that it will do according to the gravity as well as the mean pressure on the patient. So how we do it? So how we do it with the help of as soon as the aortic cannula is placed inside the aorta, we can do it from the line is connected to the arterial filter, and arterial filter's small purge line is connected to the sampling manifold, and sampling manifold is connected with the hemofilter. So it is all sepsis is maintained, asepsis is maintained, so that filtering volume is coming out, and the external the which is filtrate is coming out, it is collecting in the bag, and the blood remains to go in the reservoir. So this is the schematic diagram that from aortic cannula we can connect directly to the sampling manifold. Line is connected as a sampling manifold. We connect there as a hemofilter, and we have to the basic technique is just to clamp the outlet of the hemofilter. As soon as we clamp the hemofilter and the line is open to the aortic cannula, it will filter it out. The volume, during this procedure, the first minute, the volume is coming out in a very large amount, and if we find it difficulty to getting the volume out, so we can release the clamp for 30 to 40 seconds. So in that 30 to 40 seconds, the washing out takes place inside the hemofilter, and then again we can clamp, and again the fluid will come out. So now we will come to the research part. This is all about the rough. Then how we did the research? We did the total 60 adult patients who have participated, in which inclusion criteria that we take all the adult patient, that is age between the 25 to 75 years of age group, and weight more than 35 kg, and those who are going with the case surgery is going on with the hemofilter. And what we had excluded is the redo surgery, the second time surgery occurring, and the all emergency cases, like a patient came to emergency and we planned for the surgery, so it is avoided. And the patient waiting for a transplant, or a patient is on ECMO support, we had avoided in that. And the severely anemic patient we had avoided, and the patient with the low ejection fraction. So our sample size was calculated with the help of a calculator which is online available as stat.ubc.ca, and our study was duly institutional ethics committee approved. And what we do in the randomization is we divide the patient in both of the group by just flipping the coin, and we kept the one of the nursing guy to collect the data, so that we should not have any bias in that thing. And group A was in the hemofilter with the conventional technique like MUF, CUF and ZBUF, and the group B with WAP and RIP, and after that we do RUF in the group B trial. In India, we have to do register for the clinical trial. If we are going to do any clinical trial, we have to register for a clinical trial registration. So we had registered for the same also. So what was our hypothesis? Our hypothesis was that if the patient gets blood transfusion, it means our technique is not effective. And if the patient does not get the blood transfusion, it means that our technique is effective. So the study was started in the March 16, 2023 to October 30, 2023. This is the time when the data was getting collected. It was conducted in the department of CTVS and Sunderlal Hospital, CSSB, that is Banaras Hindu University, which is located in the Purvanchal region of India. And the consent were obtained from both the all the participants. And what we kept constant in both the groups, that is the technique of fluid removal, doing RAP and using oxygenator, custom tubing pack, VCD and hemofilter size, that is remain constant, and the RAP and WAP. So what we analyze the arterial blood gas as it is the most reliable thing available while we are doing the surgery. And what we did is first we did the baseline ABG before doing any technique, and we had collected the second sample of ABG just after going 3 minutes on the bypass, and the third sample is collected, that is the post cardioplegia given. So we will judge on these three main topics. So we did biostat with the help of SPSS software, and that is IBM version 20, and we had applied t-test and 2 sample Wilcoxon ransom tests. These are tests applied to the result data, and the data is presented in the mean and standard deviation form. So we had the results. The results in the demographic data, you will not see any significance. That means the bias is not introduced, means bias is avoided. So there is no bias between the group of male, female, and the with respect to age and the blood groups. And if you look for the mean arterial pressure, the comparison between both the group A and group B, the baseline mean arterial pressure was not significant, and when we go on the pump, there was a bit difference, but post cardioplegia there is a large difference. Why this large difference has been coming out? So we had think and got to know that in the group A patients, they have hemodilution, which is the priming solution of 1,000 liter. But in the group B, where the hemodilution is bit introduced, but there the priming solution is almost 600 to 650 ml maximum. So when we came to see it on the graph, it looks a bit significant in the post cardioplegia section. So what we had got in the hemoglobin. So when we come to the watch the hemoglobin, in the pre-bypass, we will see that in the group A there is a significant increase in the hemoglobin, as the patient's baseline hemoglobin was high in the group A, but in the group B it was slightly less. but it is a significant. But when we go on the pump, the dramatic result we will see is the more fall in the group A and the less fall in the group B. But after we see in the post cardioplegia, the hemoglobin is going more or less down, decreasing towards the cardioplegia given. But in the group B it was maintained. That is here the main function comes of the renal function, because the hemodilution is massive. At that time kidney slows down. It needs pharmacological intervention in that. But if hemoglobin will maintain, it will remain the significant. So that is why. But we had applied t-test with the comparison thing, so we had got to know that it was only 0.83 difference from pre-bypass and post cardioplegia. That is a 0.83, means 0.9 is a small difference between the patient going on pump and remaining baseline. So okay, so what we got in the main result is that non-rough patients were performing still bad, and but the rough patient were performing good, as we can see in the graph. So what we had came across the problems which we kept in the discussion, that hemofilter, we had got one of the article that hemofilter is safe in adult and pediatric as well as, but needed to closely watch the electrolytes. So in that case we had a sudden fall in the chloride and calcium levels in the rough group, where we see aggressive rough, that chloride has been significantly decreased in our group, and but not in the group A, and the calcium is remain low in our group rather than to comparison to group A. So there is one more problem to identify, that while in the first minute the hemofiltration volume will be very high, but in the second minute the hemofiltration volume is very low, and the third minute it is increased. The second minute it decreased just because the accumulation of the blood occurs because of the clamping at the clamping at the outlet. But when we release it for the 30 to 40 seconds, it becomes more again the blood inside it washed, and the thing remains the same, and hemofilter is increased. So what we had, we conclude the session with the help of that thing, that rough technique is safe and used in adult, that can be used in cardiac wall surgery patients and also CABGs going on cardiopulmonary bypass. It was helpful to avoid transfusion of allogenic PRBCs. The technique is becoming necessary in case of Jehovah's Witness, which also says the same thing, that you cannot transfuse as the blood. So this technique was showing a positive response towards saving the own patient's blood. So that's how we rejected the H0 and the H1 is accepted, and our technique is efficacious. So what we had the limitation in our study, that is we did not perform this procedure in the pediatric thing, and as we do the pediatric cases with the priming of blood. So in the priming of blood we needed to do the pre-bypass ultrafiltration. So that is the best solution, I think. So here we conclude. Thank you for this giving me an opportunity, and I would like to put the quote that when we think about to avoid the hemodilution, it was impossible to see, but when we did it, it was easy. Thank you. Thank you for your time.
Excellent job. Thank you. This time I'll bring up the presentation. Okay, we're going to get moving along here with our next presentation. Our next presentation will be by Dr. Castro, and he's going to be speaking to us today on enhancing perfusion insights through retrieval augmented generation technique and ChatGPT. Thank you so much.
Okay, thank you. Thank you for this presentation. Well, I'm Martí de Castro, and I'm the head of AI at Birmedex, that is a startup based in Spain. And well, I'm here today in order to present the work that we have been doing with all the team and I, in order to bring closer the AI in the perfusion world. So before going in depth, before going in depth with the details, just let me put a little bit of context. So, since its launch in November 2022, the ChatGPT gained a lot of popularity, having more or less, within a matter of 5 days, a user base of 1 billion of people that were using this. This underscores the widespread adoption across multiple different professional domains. But this rapid integration was not the same for all the domains. There are still all sectors that remain a little bit cautious on the adoption of this kind of technology, and one of these sectors is the medical industry. So quoting a review of ChatGPT within the healthcare domain, it specifically says that this is useful in laboratory environments. The study that we conducted in order to see, the study that we conducted at our company is try to see if we can just move beyond the laboratory environments and put that in a real world applications. So our first initial exploration in order to see if that was possible was to ask general questions regarding extracorporeal circulation to the ChatGPT. After several weeks and several attempts and a lot of questions, what we realized were mainly two things. The first thing is that we definitely need to give a lot of context to the questions that we are making in order to don't be ambiguous for the ChatGPT. So it's a lot of work that we need to put all the effort in order to make it in an understandable context for him. Then, on the other side, what we also see is that all the responses that we obtained were very verbose and with a lack of precision. So basically, what we wanted to do is to use the new techniques that were emerging on AI in order to assess if we can just improve the performance of ChatGPT, incorporating this technology that's called retrieval augmented generation, also known as RAG. So, to compare the performance of the different models, what we did is we used three different models. First of all, we used the plain ChatGPT. Then we use a contextualized ChatGPT. That basically the idea is to enrich all the information that it has, giving general concerns about perfusion and also some personality traits. And finally, what we did is to use this RAG system that basically the idea is that we can provide a specific context for each question of the user. So this gives really an enhancement in the way how the AI can understand what we are asking to it. So to a little bit understand the technology, how is it working, I'm going to explain a little bit this graph. So basically, this graph is that when we have a user, we are just generating a question, asking a question to this chat. In AI terminology, it is called the prompt. So basically, what we have is that we have a prompt from the user, and if we are using only the ChatGPT, the plain ChatGPT, without any contextualization or either any RAG system, basically what we are doing is just passing this through the AI model, and then we obtain an answer. This answer at this point is highlighted in orange. Then, regarding the contextualized ChatGPT, what we have is like we are also giving a prompt to the chat, but in between the prompt and the chat, what we have is a context about general concepts on extracorporeal circulation. This put a little bit of context on what we are referring when we are asking questions to it. And finally, there is this RAG system that actually we call it DEX, that basically there is a step before passing the prompt. So first of all, what we did is to collect a lot of documents, relevant documents and relevant publications, and what we did is to create an index. This index basically aims to retrieve any kind of a specific context regarding the prompt that we are giving to it. So anytime that the user gives a prompt, before going to ChatGPT, what we are doing is looking at our index if there is any context in relation with the prompt that we are doing. Then, from this context, we are obtaining different parts of the document that could guide us in answer the question that we are giving. Finally, all this information is given to ChatGPT, and then we have this answer that is highlighted in purple. So yeah, with the set, we move forward to the method. So what did we do in order to assess all these three models? Basically, what we did is to get the examination test of the perfusion based on the examination AMSEC test that is available in the guidelines. And then what we did is, in this test we have two different questions. One questions that are just theoretical questions, general questions regarding perfusion, and then we have some user cases that basically we have a patient with certain parameters, and then what we are doing is answering questions regarding each use of case. So basically what we did is, on the one hand, get all these tests and pass it to all of the three models, and we did that 10 times because we wanted to check two things. First of all, the accuracy of the answers, and another thing that we wanted to check is if it was the consistency of answering the test. So this is the first study that we conducted, and then we also asked them open answers in order to see the verbosity and how the ChatGPT was answering to us. So here in this first table, what I am presenting is the accuracy that we obtained after passing all the tests to the three models. What you are seeing in this table is the number of times that each chat correctly answers regarding all the questions. So for the theoretical questions, the first step that we pass, we have like 19 questions, and here we can see the different answers. Actually, if there is a 10, that means that it answered, that the model answered correctly the 10 times, and if we have another mark, it's just the number of times that it correctly answered. The same we did for the different cases, so it's exactly the same. What we can see here is that after passing this model 10 times, the one that performs the best in both the theoretical test and the case is the DEX, the one that is using this retrieval augmented system. Then in order to assess the consistency of the model, what we did is this other table, that basically what we are seeing here, just in the numbers, is the number of times that we are having the same question or a different question along the 10 attempts. So basically, when less is the number, the better is the answer. So what we can see here is that the one that performs the best was, the one that has a more consistency was the context for the theoretical questions, and the plain chat in the user cases. However, with these results, we also wanted to understand which one not only answered consistently, if not which one answered consistently, and of course correct, because at the end what we wanted to say also is the accuracy. So what we did, these are the ones that are highlighted in green, that basically are the correct answers on each of these chats. So finally, what we see is that the one that performs the best, again, is our rack system, is the text, together with the context in the theoretical questions, and together with the plain ChatGPT in the cases. So another thing that we wanted to highlight from here is that in some cases we were not able to tune the model to have like good answers along all the tests. What I mean with that is that it seems like they were answering in a random way, But after we just test that, and we also look at the different questions, what we found is that these questions were really difficult. It was challenging to find information from it in the literature. So this also was like something that we note that some of the tests that we were using, some of the questions of the test could be a little bit ambiguous. So, okay. So yeah, to conclude this, basically, what we want to say is that we use the in-context learning, and this prompt engineering helps on the ChatGPT performance, but of course we have a refinement in order to have the proper answers of this. Then the integration of the RAG, the integration of this system improve the accuracy, as we can see, and also we have a better consistency along all the questions, sorry. Then finally, the user experience in chat, of course, it's not the same that when you are asking just test questions. So it goes far beyond answering these questions. And finally, the main idea is that here we can even improve each performance because we can just add more documentation and more specific information about it. So yeah, just I wanted to thank you for just listening me, and I want to say that we are also here. We have a booth at Birmedec, so you can test the text, you can test the system, and of course you can test our other products. So thank you very much.
Thank you for that. I'm excited to hear the conversations around that. I think people are going to have lots of questions. It's exciting. Bring up the next one here. So we are going to jump ahead in the schedule here, and we are going to have our student. We're excited to have a student join us today from Rush University, and we have Miss Solimene speaking to us today on is the use of inhaled nitric oxide beneficial for patients with pulmonary artery hypertension during ECMO. We're super proud of her coming up here today. So we are going to bring up her presentation, and then, there it is, there it is.
Okay, how do I get it?
Yep, and then here. There you go.
Okay.
Yep. And then I'll give you 2. Great job.
Good morning. My name is Victoria Solimene, and I am a first-year perfusion student at Rush University in Chicago, Illinois. Today, I will address the potential benefits of inhaled nitric oxide for patients with pulmonary artery hypertension during ECMO. I have no disclosures. Before I discuss inhaled nitric oxide, I must first define pulmonary artery hypertension. PAH is defined as elevated blood pressure in the pulmonary artery due to narrowing or constriction of the vasculature in the lungs. A variety of diagnostic tools are available to confirm the diagnosis of PAH, such as right heart catheterization, echocardiography, and other imaging techniques and laboratory analyses. One could speak for hours about this very subject, but for the sake of time, I'll provide you with a brief history and overview of inhaled nitric oxide therapy, as well as current research on the topic as it pertains to critical care settings and ECMO. Inhaled nitric oxide has had its place in pediatrics. The late Dr. Warren Zapel, critical care physician, pioneered therapeutic inhaled nitric oxide therapy in newborns suffering from hypoxia as a result of primary pulmonary hypertension. Once considered a radical and dangerous gas, inhaled nitric oxide had its therapeutic emergence in the 1990s. Its 1999 FDA approval to treat hypoxic respiratory failure in near or at-term neonates with pulmonary artery hypertension remains the only FDA indication for use. Nitric oxide, formerly known as endothelium-derived relaxing factor, is produced from L-arginine and endothelial cells endogenously, and acts on smooth muscle to relax and vasodilate. Nitric oxide rapidly binds to hemoglobin and degrades to methemoglobin, and it is ultimately excreted as a nitrate metabolite in the kidneys. Available systems for use in North America are primarily cylinder-based systems, which include the Inomax delivery systems, An emerging technology includes chemical-based cartridge systems, such as the Vero Biotech Genicil delivery system. As a perfusionist, you may have encountered inhaled nitric oxide in the operating room, from lung transplants to heart transplants, in VADs to right-sided support when coming off bypass. The application potential is robust. Understanding adjunct therapies, therefore, is a critical component of perfusion. Selective pulmonary vasodilators are often used to avoid the need for ECMO. However, a certain subset of patients may require both therapies at the same time. The use of inhaled nitric oxide therapy could be the difference between staying on ECMO longer versus coming off ECMO sooner. Based on a preliminary literature review, I have found research regarding inhaled nitric oxide during adult ECMO to be scarce. And although this topic may seem exceptionally niche, the COVID-19 pandemic has revealed the potential for such therapies to be used in conjunction with one another. In this case report out of the Netherlands, inhaled nitric oxide was seen to have benefited a COVID-19 patient with severe ARDS requiring VV ECMO, improving both pulmonary hypertension and ECMO recirculation. This case report followed a 49-year-old male who presented to the emergency department with progressive dyspnea. A CT and nasal swab confirmed COVID-19 pneumonia. The patient was admitted and 3 days later was intubated and mechanically ventilated due to poor oxygen saturation despite optimal oxygen therapy. The patient was proned in the attempt to improve severe and persistent hypoxemia. On day 6 of admission, the patient was cannulated for VV ECMO with initiation flows of 4.5 liters per minute, a sweep of 3.5 liters per minute, and an FiO2 of 90%. A post-cannulation transthoracic echocardiogram revealed satisfactory RV and LV function and a 21% recirculation fraction via ultrasound dilution. 4 days after ECMO initiation, the patient was started on CRRT due to progressive renal failure. Hypoxemia worsened despite maximal ECMO and ventilatory support. A repeat TTE revealed significant dilation of the RV due to RV pressure overload, in addition to TR. RV systolic pressure was greater than 50 millimeters of mercury, LVEF was 45 to 50%, and the recirculation fraction increased to 50%. Cannulation was still optimal at this time. The patient was given an initial and second dose of iloprost, an aerosolized prostacyclin analog to improve pulmonary vascular resistance. Due to a lack of improvement, inhaled nitric oxide therapy was initiated at 20 parts per million and increased soon after to 30 parts per million. The patient's PO2 increased and oxygen was therefore stabilized. A follow-up TTE revealed a significant reduction in RV dimensions with good contractility and no TR, as well as a significant reduction in recirculation. 24 hours post-inhaled nitric oxide initiation, cardiac output and mean arterial pressure also improved. The patient showed a significant improvement from a respiratory perspective and followed a good clinical course shortly after inhaled nitric oxide therapy was started. Unfortunately, however, the patient succumbed to a superinfection with multi-organ failure and died. This figure demonstrates the progression of the patient's recirculation fraction and PO2 over time in relation to INO administration. As you can see, the recirculation fraction increased from 21 to 50% over a period of 24 hours prior to initiation of INO therapy, and decreased back to about 20% after INO therapy was initiated. This table highlights echocardiography findings as well as ventilator and ECMO settings in relation to INO administration. Of note, the RV diameter returns to normal 12 hours after INO administration, and the tricuspid regurgitation falls from severe to absent 12 hours after INO administration. Furthermore, recirculation also falls from 50 to 22% over a 24-hour period on INO. This figure demonstrates a structured approach to hypoxemia on VV ECMO. The bottom right box entitled Reduce RV Pressures in TR is the area of interest in this case report and ultimately this presentation, which can be achieved by selective pulmonary vasodilatory therapies such as INO. Some advantages of inhaled nitric oxide included selectivity for pulmonary vasodilation devoid of systemic vasodilation, its potential to improve or restore VQ matching, and its relatively low toxicity if used correctly. On the other hand, inhaled nitric oxide carries the risk of severe rebound pulmonary hypertension if abruptly discontinued due to its short half-life. Furthermore, methemoglobin levels should be closely monitored during inhaled nitric oxide therapy, and flows must be optimized to avoid nitrogen dioxide formation. Alternative intravenous and inhaled therapies are listed here, which include both local and systemic vasodilators. Some are used independently, and some are used in conjunction with others. Of note, epiprostenol or Velitri is a nebulized prostacyclin analog used to treat pulmonary artery hypertension in the intensive care setting. This presentation is simply food for thought. Evidently, the average intensive care patient often requires a unique cocktail of therapies to aid in improvement and recovery. Research regarding inhaled nitric oxide therapy in neonates, both on and off ECMO, prevails. This by no means was an expansive literature review on the adult side of things, but it is a step in the right direction in my professional journey as an aspiring perfusionist, and I very much look forward to future work on this subject matter. I would like to thank Rush University, specifically Julie Collins and Allison Weinberg, for guidance on this project. I would also like to thank AMSECT for providing me with this opportunity to present here in New Orleans. Thank you all.
Is Miss Amber Palmer here? Perfect. Please join us. Wonderful. We have one more presentation, and then I know that we are supposed to escape into exhibits, but I would love to stay and have a quick conversation. And I'm kind of bossy, so you can hang out with us for a little bit longer. We'll have a couple questions, and I know you have questions as well. And then we will head into the exhibits from there. Oh, sorry, this mouse is so picky. Wonderful. So as I mentioned, Ms. Palmer is going to speak to us today. She just hopped over from the pediatric session. Congratulations on that. She's going to be speaking to us today on the University of Pittsburgh's Medical Center's experience with normothermic regional perfusion for donation after cardiac death. Just over here, right down here. Oh, I see. Okay. There you go. Great. And if you're going over, just kidding. Nice too. Thank you.
All right. Hi, everyone. I'm Amber, and like she said, I'm going to be just talking about UPMC's experience with normothermic regional perfusion after cardiac death. So real quickly, I just have a few learning objectives, what we're going to go over. The pre-withdrawal preparation, our NRP procedure that we do at UPMC, and post-procedure outcomes, and just have some concluding thoughts. So I wanted to include this graph, well, it's a table actually, of brain death donors versus donation after cardiac death, because you'll see that there's a lot of similarities between the two, but the diagnosis and prognosis aspect of it is that the brain death donors are book brain dead. They meet all the criteria, whereas donation after circulatory death, they don't necessarily meet all the brain death criteria, but they have a prognosis that is not hopeful, and that they, so an unrecoverable anoxic brain injury. So what do we do for the pre-withdrawal preparation? So once the family gives authorization to go through with the NRP procedure, a multidisciplinary discussion occurs. So you would think the doctors from your recipient and donor hospital, your OPO who's in charge of planning all the procurement, and then we have CORE for Pittsburgh. So CORE is a procurement organization that also is involved with everything. So they discuss, they look at the lab results, they look at a cath and TEE to make sure that the heart actually looks good and is viable. Again, we talk with what the family wants. A big part of this entire procedure is what the family wants. So where is this therapy going to be withdrawn? Is it going to happen in the OR or is it going to happen in the ICU? Because that makes a huge difference from a perfusion standpoint and really on the whole process. Do the family members want the patient drepped and prepped and ready to go, or do they want their loved one to be as they are and then go naturally, and then when the time comes, we come in the room and we drape? Sometimes the family just wants the handout. So you really have to go with what they want, and if their requests or their wishes are more than what you can handle or more than what your hospital is willing to go for, then this might not be a candidate for you. We also discuss what their wait time is. We've had hospitals that we've gone to that they say once you make withdrawal, you can wait 60 minutes. We've had other places that say you can wait up to 2 hours. So that's really the donor hospitals' protocols and standards. We find some states are a little bit more strict than others that we've gone to. So again, there's another huddle when you get there. So once we, as the perfusionists, get there, we talk to the doctors, the surgeon, anybody who's in the room, the procurement team. So a lot of the time we're coming to get the heart, but there's also somebody that's there to get the liver. So we talk with everybody, we get everybody on the same page. We say, hey, I'm Amber with Perfusion. This is what I want to do. This is what I need from you guys. We talk with anesthesia because that femoral art line is very important during this whole procedure. You can't use a radial because the head vessels are going to be clamped off during the procedure. So you really need to have a femoral A-line, or they can hook an aortic root pressure, but we really prefer to have the femoral line. We also have to confirm what that no touch time is, because we can be scrubbed in and ready to go, but we can't touch the patient for 2 to 5 minutes, and that's dependent again on the hospital. Another big one for a perfusion standpoint is heparin. When's heparin going to get administered? We always do it prior to withdrawing support. We give it a good amount of time so everything can circulate and nothing's going to clot off. Big key for all this is communication. You just have to talk with the team that you're with and make sure everybody's on the same page. So this is our circuit. It's a Soarin' Revolution on a little perfusion trolley. We now have upgraded from an FX 15.5 to a FX 2.5. We need the oxygenation. We probably should have started with the bigger oxygenator to begin with, but it was kind of trial and error. And then it's a half-inch venous line. We have a level sensor, but no E-clamp. It just alarms to say, hey, you're getting low on volume, do something. And then we have a vacuum regulator. So it's very simplified and very portable. We also have our red Pelican box, which is basically your perfusion case cart. So during normal bypass case, you have a big case cart. This is basically our case cart condensed in the box. We use an iStat, and then we also have a drug box that includes all of our prime drugs and then some miscellaneous drugs that we use during the case. We also have the cannulas that the surgeon's going to use, extra syringes, really anything that you can think of, it's probably in that box. So here's the packing list. This is just some of it. We use a 29 French triple stage venous cannula, and then we use a 20 Femflex arterial. And just your standard PIC-A and Soarin' dilator kits, nothing fancy. This is our prime list. And we also, like I said, use miscellaneous drugs. So we'll give extra bicarb and calcium when we're on pump and actually seeing what the patient's gas looks like and what we should do from there. So our procedure, so we went through the pre-withdrawal phase, we went through the huddle, now we get to the OR, we drep and hopefully prep and drape. We give that heparin, like I said, we withdraw the care, and then we wait. We wait for them to pronounce that they either went into asystole, went into a PEA, or they might not even pass. So it just depends on how sick the patient is and what we're gonna be doing. So once we get through that phase, we go into the maintenance. So the surgeons are typically ready to go, they're gowned, they're draped, and when we are escorted to a different room and we're sitting there, they're scrubbed in the entire time waiting for an hour to up to 2 hours. During these procedures, we can't be in the room during withdrawal. So we're completely separated. We don't see the family. We're not involved in any of that pre-withdrawal phase. We talk about, we have a timeout, and then we leave the room. So at this point, the donor is passed. We're gonna make sternotomy. They included the head vessels almost immediately. They put the venous cannula in, and then if you're the lucky assistant, you're sitting there and you have to hold that cannula and make sure it doesn't go anywhere, because we don't put purse strings in until we're on pump. And then we immediately drain out as the perfusionist. So we want to decompress that heart and get it as empty as possible. During that time, we've recently been opening our recirc line and letting the blood sort of pre-oxygenate while they're getting that aortic cannula in to kind of keep up with everything. And it seems to be working. We are not as far behind when we go on pump, because these patients have some really dark blood when you go on. So we want to make sure we're staying ahead of the curve. And then we do the arterial cannula. They just put in a dilator kit, and then we just make sure that nothing dissects out. They do a syringe bleed back on the cannula, and then I always check for air, because sometimes a little pocket of air gets in there, and then we go on pump. So it's a really quick procedure in terms of getting on pump. So once we're on, everybody kind of calms down a little bit. There's high tensions in the room prior to going on and get that excitement, but once you're on, everybody sort of takes a breath, and then we reevaluate. So I'll draw gas, I'll do whatever I need to do on the perfusion side, and then at that point, the liver team or the other procurement teams could get in there, and then the surgeons are also working on securing those cannulas down. We take 2 perfusionists on every procurement. I say the one perfusionist is really there to focus on the pump, make sure they're stabilized, doing everything that they're supposed to be doing. And the other perfusionist is sort of running around doing everything else. So they're running the blood gases, they're drawing the drugs. The liver team is often needy, and they want lactates every 15 minutes. So we'll do that for them. So we kind of are, and then we're also communicating with the surgeon back home in Pittsburgh, saying, hey, heart looks good, here's the gas. Sometimes we ask what they want us to do with it, and we go from there. So let's say everything looks good. We get a TEE at a half hour, and if everything looks good, we say, all right, we're gonna take the heart. We give the other teams time to do what they have to do, and then we just hit the heart with the cold cardio, package it up, and off we go, back to Pittsburgh. So this is our data. We've done 19 since 2022. Our average time from death to bypass is 23 minutes, and our average time from bypass to normal sinus rhythm is about 9 minutes. I say the average time of death to when we're actually on pump is really dependent on what that family's wishes were. So if they are okay with the drape and prep, then you're getting on pretty quickly. But the ones that we have to wait, it's a little bit longer. So just in conclusion, we've increased our transplant list, which is great. We've only had 1 ECMO go on post NRP procedure, and we're kind of starting to extend into the ex vivo portion of NRP. So that's kind of exciting. But thank you for listening. And that's all I have for you. Awesome.
Awesome, awesome. Thank you so much to all of our speakers this morning. I know it's tough to get up here. I love it. I always love the abstract session because I love to hear what's going on around the world outside of my little home place. But I always love too, it's always fresh faces, and I love that. I just love hearing what's going on. So again, I know we're supposed to be over in exhibits, so if you would like to go to exhibits, you're welcome to. But I would really love to have at least a few minutes for questions. We do have some online questions. Luke is going to handle all of the questions, but if there's anyone that would like to step up to the mic and ask our abstract presenters a quick question, I'm sure there is a ton of questions going on. And you can, of course, always reach out to them afterwards.
Bob, go ahead.
So you're accepting questions? Is that what I heard?
Yes,
Yes.
for all abstracts.
Yes.
For all abstracts.
Thank you. This was a great panel this morning. I enjoyed all the presentations. I have a question for Dr. Condello about his study looking at comparing 2 pumps, comparing the vortex with the magnetically levitated pump. And now those were done for CPB cases for coronary surgery. Is that correct, your evaluation?
Thank you for your question. In this context, we use the magnetic levitation pump with minimal invasive extracorporeal circulation, without the suckers and without the use of roller pump in this context.
Okay, so that's the difference between the groups.
Yep.
So I'm only aware of one evaluation of those two pumps that was published in 2010. It was a comparison of the constrained vortex to the rotoflow pump for ECMO application. And that study found that the two pumps were very comparable in mechanical function, but you saw some pretty striking results in hemolysis and other things. I was curious that it looked to me like, maybe I read this wrong, but there was 3 units of blood transfused in the magnetic levitated pump and 9 units in the vortex pump. Is that correct?
Yes, it's correct. Because in this study, we use high rate of level of hemoglobin. Okay, for you prevent the hemolysis in the constrained group, you work with the threshold between 8-9 gram deciliter of hemoglobin. In this context, we use a high level of hemoglobin to evaluate. I believe that this is the discriminant factor in this study.
So that could have influenced the difference in hemodynamic or hematological parameters, you think, the transfusions?
Yeah, the transfusion, I believe that the hemolysis in this context increase the rate of transfusion after the 48-hour, because the hemolysis increase the inflammation. The inflammation improves the systemic inflammatory response syndrome. The patients give liquids to resolve the problem of hypotension, no? And this increases the transfusional rate. This is the observation of this study. Today, we not observe the hemolysis in the long-time pump, but have adverse effects such hypotension and increase the fluid therapy to improve the hemodynamics.
Thank you.
You're welcome.
And just one small question for Dr. Cross about your work with AI. I really don't understand AI well, but one thing I worry about with it, and maybe you can help me to overcome my fear. You know, if you do a systematic review of the literature, someone looks at the literature and there's a wide net cast and we get a lot of literature. And the thing that concerns me about AI is how is that data evaluated? I mean, what if you're looking at a lot of publications that are not really well done? How is it evaluated when you use AI?
You mean evaluated to train this kind of models or in our study? I mean, the way that we evaluate all this information basically is by ourselves. So we decide which is the one that it's relevant for a specific, and then inside the model, what we have is that translation, let's say, because at the end, these kind of models do not understand the same language that we are talking. So there is a transformation here where all this data is passed through natural language, that's the one that we are speaking, to vectors that basically are numbers. So then using this system that it's called embedding systems, it is able to recognize the different sequences of words, and then you can compare how similar the words that you are talking, that you are prompting in this case, are from all the information that you have. So let's say that there's an extra step in evaluating all this information before passing to it, that it's just, let's say, translating all this information into a machine. I don't know if I answered your question properly and you were referring to what I explained.
Thank you very much. I'm still uncomfortable about AI, but thank you.
I can understand that. I'm a little bit uncomfortable too.
We're going to do one quick online question.
Yes, the question is for Dr. Akhalesh. How long does it take to do the RAF procedure?
So actually, it's a combined group work. So if anesthesia and the surgeon are convenienced to give, but maximally they give 3 to 4 minutes maximum.
Okay. And do you use vacuum on your
No,
hemofilter?
no.
Just gravity.
Yes.
Okay, thank you. Oh, we have a question from the
Oh,
audience.
sorry, you can't see.
Hi, I'm Juan Blanco from Spain, and I have a question for Mrs. Amber Palmer about NRP. We are one of the most active centers in our country of TA-NRP with more than 27 cases. And we struggled a lot with our regulation about cerebral reperfusion. So you mentioned that you do clamp the supraortic trunks to avoid cerebral reperfusion, if I understood well. And I'd like to know if you do any kind of control of the effectiveness of this cerebral reperfusion, and if is there any kind of regulation here to, well, in this regard.
So for, can you hear me? For UPMCs, we have not done anything with regulating cerebral perfusion, nothing to keep track of that. It's definitely a great suggestion on something to consider, but we have not done that yet. And we also haven't had any issues once we clamp off those head vessels. They're kind of, in lack of better terms, out of sight, out of mind. So we're kind of not even worried about the head vessels at that point. We're just worried about getting that heart back. So, but definitely a great suggestion on keeping track of it.
Yeah, what we do normally is to cut down and we aspirate all the blood to avoid overpressure. So if this could be helpful somehow.
Yeah, definitely.
Juan, I want to make a remark on that. So at the Catholic University of Leuven in Belgium, they also do NRP, and they now stopped all their NRP because they're going to do a trial to see if when they do the cutoff or the occlusion of the vessels, if there's actually no blood flowing anymore to the brain. So there is some concern about that, about the definition of brain dead, and so they stopped their NRP program for the moment, and they're going to do a trial.
Yep. This has happened in several centers, also in the UK. And we are now in a study proving that there is no efficient cerebral reperfusion with radioactive isotopes and gamma camera, and also we are starting adding to the pump atropine because of its direct activity on the central system, and there is no action. So, well, I mean, cutting the supraortic trunks may be a good option to avoid these legal burdens or ethical burdens.
Thank you so much. Listen, I know everybody has a ton more questions. We have a lot of online questions that we didn't get to, and I apologize. Oh, I'm so sorry. I have my whole list of questions as well, but I really want you to have a chance to get to the exhibits. We wouldn't be able to host a meeting without the exhibitors. So please take about 45 minutes to see the exhibitors, say hi to them, but please be back here at 10 o'clock for the next session. Thank you so much to our exhibitors this morning, our speakers this morning. Thank you. Did so well.